Good morning, and thank you for the invitation to speak today. My topic is the dermatologic phenotype of DATA2. And so I'm going to discuss the patients that I've seen on the NIH Dermatology Consultation Service over the last several years. And so these are patients of Dan Kastner and Mandy Umbrello. And we're going to focus on the primary findings of vasculitis and livido, but we'll spend a few minutes talking about a few of the other associations as well. Overall, about 90% of patients who have deficiency of ADA2 will have one or more cutaneous features. The livido pattern is most common, and that's seen in about 3/4 of patients, but the vasculitic features are often seen at least in half of patients as well, and this can resemble polyarteritis nodosa or leukocytoclastic vasculitis. So we'll start first with the cutaneous vasculitis features. And again, these features are impossible to differentiate from cutaneous polyarteritis nodosa. So this is a vasculitic process involving the small arterioles and medium-sized vessels. So primarily seen in the deep tissue, deep dermis and subcutaneous tissue and skin biopsies. Clinically, it presents as small inflamed nodules that are often tender to palpation, somewhat ill-defined, and a little bit different than the classic purpura you would see with leukocytoclastic vasculitis. Most common location is the lower extremities, but certainly we see involvement of the upper extremities as well. On the right, this is a patient who had biopsy proven PAN-like involvement of the skin, and then at subsequent visits, she went on to develop a more typical livido pattern as we see in DATA2. Histologically, as I mentioned, this is a vasculopathic process of the medium-sized vessels and arterioles. And so the capillaries are going to be spared. And so the pathology is going to be in the deep dermis and subcutaneous tissue. Here you see a transluminal neutrophilic and lymphocytic infiltration of the vessel wall, as well as fibrinoid necrosis of the wall itself. And so this is very classic for vasculitis. You can also see the pattern of the biopsy here. So this is a punch biopsy, and most of the biopsies that we have done have been punch biopsies, and we'll talk a little bit more about the limitations of that in a second. Here we obviously have one nice large vessel in the specimen, but there is the potential for sampling error. Another example of a punch biopsy specimen. This time we're fortunate in that the vessel was actually cut transversely, and so we again see a nice example of that transluminal infiltrate and fibrinoid necrosis extending all the way through the wall. Moving on now to the livido pattern in the skin. In dermatology, we always want to show the most extensive, impressive skin pictures, but I think it's important to start with actually some of the more subtle involvement. And this is actually one of the differences, as we'll do a little comparison later with classic livido reticularis. Many patients have just patchy involvement of this livido pattern of the skin, and it can be quite subtle. And certainly we see patients who we know have DATA2 who don't have any visible livido pattern to the skin at all. Again, an example of sort of more localized involvement where really the livido pattern is localized primarily to the distal thighs and the area. Another example of sort of this patchy pattern with the most prominent visible area of a livido pattern over the legs. And I'll just highlight on the right thigh here, you can see the downside of doing a larger incisional biopsies is you do have larger scars that patients, particularly young patients, are going to have to contend with for the rest of their life. The most common location is going to be the lower extremities for livido pattern, but we certainly see upper extremity involvement frequency as well as involvement of the torso. In patients who don't have the sort of nodular lesions of PAN, I would say most patients are asymptomatic with their livido. And again, a few examples showing this patchy involvement. And histology, I would say, is a little bit uncertain. Certainly there's the potential that we have sampling error because we do primarily punch biopsies sort of on the fly in dermatology clinic, whereas the general recommendation if you're trying to rule out cutaneous PAN in the vasculitis setting is to do a larger incisional biopsy in order to be more likely to capture one or more medium-sized vessels. So it is possible that we're not capturing vasculitis in most of our livido patients because we're doing typically a relatively small punch biopsy. But what we've seen the vast majority of the time when we do biopsy these patients is an interstitial infiltrate of neutrophils and macrophages, as well as some dilated capillaries in the dermis. But again, how much of this is sampling error is I think, something we could debate. So I'm going to spend a few minutes now talking a little bit more about terminology. And so this on the left is a classic patient with livedo reticularis. And you can see there's a very nice net-like pattern of interconnecting erythematous sort of macular lesions. And this is a woman who has physiologic livedo that typically is going to improve or even disappear when she's in a warmer ambient environment. And the differential diagnosis for livedo reticularis is quite broad. There's a number of different diseases that can cause livedo, as well as obviously just physiologic or normal temperature-dependent livedo as well. And we're not going to go through all of these. But I did want to just point out there are other vasculopathic conditions that certainly can cause a livedo pattern to the skin. And there's even something called erythema ab igne, which is a permanent fixed livedo pattern that often will evolve into a brown coloration. And we see this in patients most commonly with chronic pain syndromes that use heating pads. But occasionally we see this also in people who have laptops and they set the laptops on their thighs for long periods of time as well. And there is even drug-induced livedo. So amantadine, a drug that we typically think of as being used for Parkinsonism, is increasingly being used off-label in the pediatric setting for neuropsychiatric conditions. It's thought that almost 40% of patients who receive amantadine will actually develop a livedo pattern to their skin. And so this is something to look out for. And I also bring up this drug because amantadine was originally developed for influenza A. And as you might expect, there's actually been interest in repurposing amantadine for COVID-19. And in fact, there is some data suggesting it may have some benefit for patients with COVID. And COVID itself is also another condition for which livedo has actually been recognized as one of the skin features. So the reason I bring this up is because I want to raise the possibility that maybe all of these livedos are not the same. So the vast majority of patients that I've seen with deficiency of ADA2 do not have a nice net-like pattern of livedo that resembles physiologic livedo. And in fact, it's sort of these irregular branches, sort of a broken pattern to their erythema. We think that the distinct pattern of livedo reticularis is directly related to the anatomical sort of vascular distribution in the skin. And so it's called an arterial cone. So these smaller arterioles make their way towards the surface of the skin and progressively branch to become capillaries. And it's at the periphery where you have this venous predominance, and that's the erythema that's seen in that net-like pattern at the edges of these arterial cones. And just to sort of show you how vascular flow is not uniform throughout the skin, this is vascular thermography using infrared imaging. And this is a young healthy volunteer who's in our infrared imaging unit here at the NIH. And excuse me, this man is on a treadmill. And so we're going to look at the temperature of his skin as he begins moving along and exercising on the treadmill. So you can see overall his temperature is decreasing, particularly his nose and lips. And then as he exercises more for 10 or 15 minutes, his temperature drops even further. And then at maximum exertion, now 25 minutes in, you can see the blood flow is markedly reduced, and a very distinct vascular pattern of these sort of feeder arterioles are the only areas where the skin remains at the relatively high temperature until his skin starts to return to normal with rest and reperfuses, and his temperature actually returns to its previous state. So I would contend that maybe all of these livedos are not the same. So on the left side, we have the classic livedo reticularis that in most cases is considered a normal variant. It can be physiologic. There are patients that have fixed livedo that's called idiopathic, that doesn't change with temperature. And then occasionally we have pathogenic livedo reticularis, and this is seen particularly with early antiphospholipid syndrome and sometimes in lupus. And then on the right side, we have livedo racemosa, where I would contend that the vast majority of the time when you see this pattern of involvement, you are going to have an underlying pathology, and it's typically going to be vascular in origin. And so this is most commonly associated with systemic lupus, with or without the antiphospholipid antibody syndrome. And in fact, there have been associations with the skin livedo presentation and a higher risk of stroke and other vascular events in patients with antiphospholipid antibody syndrome. Livedo racemosa pattern is also very commonly associated with PAN type of vasculitis, and then also classically associated with the phenomenon known as Sneddon syndrome. And so just to show you an example of sort of, again, this broken pattern of livedo in a patient who does have cutaneous PAN. This is not a patient with ADA2 and the typical nodular lesions as well. And so I'll just spend a minute talking about Sneddon syndrome here. This was described by Ian Sheffield. He was an Irish dermatologist who noted an association with adult onset but early onset stroke in 6 patients who also had this peculiar pattern to the skin. He called this livedo reticularis when first reporting it, but in fact, if you look at these original pictures, this was much more of the racemosa pattern that we've been talking about with vascular disease. And so it raises the interesting possibility that perhaps there could be a quote unquote familial Sneddon syndrome that has been reported before the gene for ADA2 was identified. And in fact, this was a report of 3 adult patients that were reported to have familial Sneddon syndrome, who had livedo racemosa, leg ulcerations, and fever. And this was back in 2013, and I'm sorry, 2003. But subsequently in 2014, Bross and colleagues confirmed that this kindred, in fact, did have compound heterozygosity in the SERC1 gene. A slightly more recent report from 2005, again, calling this familial inflammatory Sneddon syndrome. This was 2 siblings with early onset stroke, but other features which are highly suspicious for DATA2, fever, nerve palsies, and actually subcutaneous nodules, which sounds very suspicious for PAN in one of the sisters. And I didn't see any follow-up data on this one, but this certainly sounds very suspicious for ADA2 deficiency as well. And I'll just give a brief mention to a really neat study that Dr. Santo and colleagues did, where they actually compared adult primary Sneddon syndrome of unknown cause with patients with known deficiency of ADA2. And they actually found, interestingly, that low serum IgM was a relatively sensitive and specific marker differentiating true deficiency of ADA2 from primary Sneddon syndrome. So suggesting these are indeed different diseases, but the similarity in terms of strokes and the clinical cutaneous presentation are certainly quite striking. Okay, in the last few minutes, just briefly, I'll talk about some of the other associations, and I'm going to do these quickly because these are primarily case report and anecdotal level data. Ulcerations of the skin and oral aphthay or oral ulcers have been reported. On the left is a patient with DATA2 who was described really as having just a leg ulcer and livedo reticularis prior to diagnosis, but his brother indeed had PAN-like disease. And on the right is a patient with refractory oral aphthay and fevers since a young age. This patient also had DATA2, but she also had significant lifelong neutropenia. And so it's difficult to sort out how much of her component was a cyclic neutropenic type oral ulcer. But she did improve dramatically, including her oral disease with infliximab therapy. This was the only data I could find on sort of a case series level of oral or skin ulcerations. And this was a series of 9 patients with homozygous R169Q mutations, and oral aphthay was reported in 3 of the 9 patients described in this series. Brief mention about cutaneous autoimmune disease. This was 2 patients, 2 brothers, who had high titer ANA as well as a variety of other autoimmune features suggesting of a lupus-like presentation. They did have livedo and oral ulcers. There are a variety of different skin features that you can see here and that were described in this paper suggesting a lupus-like skin phenotype, but there actually was not histology associated with it. So whether or not this truly represents lupus in the skin, I think we have to say is still unclear. In terms of cutaneous infection, I think this is important to mention. So Certainly, patients with immunodeficiency get common skin infections, but they tend to get it in a more impressive manner. On the left, a patient with HPV in the setting of idiopathic CD4 lymphocytopenia, and the patient on the right, molluscum contagiosum in the setting of combined DOCK8 immunodeficiency. And so when I talk about immunodeficiencies with other dermatologists, I really emphasize that in some cases, we can be important in making this diagnosis because we see patients with warts every day. And so if the presentation is generalized varicosis, the pattern of which is shown here, almost invariably involving the hands, the feet, and head and genital area, infections that occur simultaneously. So if they have both warts and HSV or molluscum pox virus, if these infections don't resolve as they typically would over multiple years, even without treatment, and patients who have more bulky disease, these are all clues that maybe we need to think about an underlying immunodeficiency. And we have lots of patients with warts who become refractory to therapy. And so when you have patients like this, then I think as dermatologists, our role is to stop and actually slow down, get a little bit better history. And the first thing I have people do is ask the family members, are there other infections that these kids have had? And even for these patients on the right with impressive molluscum and warts, there was other infection at non-cutaneous sites. One patient had recurrent sinusitis, the other had early onset pneumonia. So there is often going to be a signal in terms of systemic infection when you see cutaneous infection as well. And the last thing I'll mention are sort of anecdotal reports of acral disease, particularly Raynaud's and distal necrosis, but also paniculitis, purpura, subcutaneous edema, and urticarial rashes. And again, these are at the case report level. I don't have good histology, and I suspect, at least in some of these cases, particularly the purpura, these are cases of vasculitis that are just presenting in slightly different manners in the skin. And so I will close on that, and I look forward to answering your questions during the Q&A portion. Take care.